Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
I'd like to welcome you here. This is broadcasting from Vive. Frank Cutitta. I'm in charge of the content with Digital Health Insights as part of Chime. And I'm happy to have Brad here coming in. We're going to be talking about something a little bit different than we do with all the stuff that's happening here. Although I'm sure every part of it is related in some way to what Brad does. Brad, could you just do sort of a short introduction and sort of a tweet of a day in the life of Brad?
That's it. Well, I'll spare the details. Brad Hawkins, I'm the Vice President and GM over Payer Solutions at MRO. MRO's been in healthcare for the past 25 years, serving over 1,200 hospitals, 35,000 practices as a release of information vendor, or in many cases, people look at it as a health information handler. I think as we've seen sort of the market change from say provider and payer collaboration standpoint, it's really my charge and my team's charge every day to say, how can we strategically align to sort of where the market's going related to health plans, their need for more and more data. Providers need to align to those requests, but also retaining some level of control around compliance and privacy. And so excited to have the opportunity to speak with you, Frank. So thanks for the time.
I think our audience is really interested in this as well. I sort of bumped into it a few weeks ago, but I was doing a session on children's hospitals.
Okay.
And it came up about cybersecurity, but one of the guests was from Texas Children.
Yep.
Which they thought, hey Frank, you should have this guy because they're also a provider and a payer combined. So it's the first that I was dealing with that, and when Beth brought this up that we should be speaking, just looking for what the dynamics are in this day and age of having them both combined. I mean, as a layman and as a person who pays for insurance, I can understand some of them, but sort of looking at the beginning, just to wrap our arms around it, what the combination of the two has in terms of giving an advantage, and what are some of the scary parts of it?
Well, I think you have to look at it from like large, the macro market dynamic, right? As we know that, got aging population, health plans are asking for more and more data annually on their membership. They're using that data to drive any number of value-based care arrangements with providers. They're looking at it from, how are we taking better care of our own membership? And so if you think about that, globally from a national health plan, a Humana and Optum, and then you drive it down to us as individual employees, right? Our employers, what's their number one expense is health insurance, right? For their employees and for their company. And so the rise of these provider-sponsored health plans has been really interesting because you would think that, they're already got, sort of the inside track on how to manage the system. But if we take a step back, they're actually under a lot of stress and pressure. I think, the biggest one that we've, kind of witnessed is they're under, I would say, scrutiny from a financial standpoint because they don't have the deep pockets and resources that the large nationals have. Mainly from the ability to really achieve scalability. And when I say that, what I really mean is scalability, meaning that they can take advantage of the technologies and the capabilities of vendors to create scale and eliminate a lot of the administrative burden. Does that make sense? So I think that's like, one of the big areas outside of being able to recruit talent in the world of risk adjustment and easier for me to say. Also looking at from a risk adjustment standpoint or coding, but also just even to the adoption and adaptation of new technologies. And so it's been interesting as we've partnered with both the providers and these provider-based health plans to start to see where there really is synergy to allow them to take advantage of kind of what's happening in the market.
So when you come to a conference like this, you're looking at it through two lenses.
Sure.
You get the payer and the provider lens. Where do you see the strongest overlaps between the two, especially as relates to the conference on digital transformation?
Yeah,
there's got to be a ton of synergies there.
There is.
There's got to be some conflicts that we operate two somewhat different worlds.
Yeah, I think there's a lot of synergy in the fact that we can all agree on we need more automation, we need more integration, we need to be able to speak to each other in a standard language or in some level of operational efficiency in the way that we're communicating. And so what that means is health system, CIO, is saying, hey, look, I've made an investment in my EHR. I want to leverage that EHR investment, any APIs, connectivity, integrations that's available there. I want to be able to extend those out. I don't want multiple points out. I want one point out to be used for multiple threads. On the health plan side, they're being pushed more and more to say, I need to get data in a certain format from a US CDI, format. I need to be able to accept FHIR. I've got to hit the NCQA, 2030, HEDIS measures. So they're under a constant pressure to do that. Yet we're still just sharing data in, here's a PDF, Frank, right? And then I'll leave it to you to figure it out on your end, right? Well, that doesn't create those operational efficiencies. It doesn't lead to scale. And ultimately, it creates a big burden for that provider-sponsored health plan because they're not just asking for records from their own provider group. They're also looking out, where else have my members been seen across this geographic area?
You're in this data business, so I would imagine that the combination of the two creates a very large target on the cybersecurity.
Oh, yeah, for sure.
So I mean, you've got all of my data on both sides where you usually have to go and break into two places.
Right.
Now you just got one house to break into, and
yeah,
it's easy to do that. You're getting the crown jewels of everything.
That's true, and I think one of the big things is, because we've really enjoyed a partnership with our provider network for the past 25 years. The reason that we've been best in class for 12 years in a row is that our providers trust us to do the right thing with their data. And so I think one of the key things that we've seen with at least the provider networks, the provider network we service, and the payers that are asking for this data is to ensure that we're collaborating on what exactly has to be shared. So oftentimes today in like a HEDIS audit that's ongoing right now, provider receives a request, they send a 500-page chart back to the health plan. Okay, it's up to you, health plan, to decipher what data is actually valuable. But if you ask the health plan what they really want is, I only need these 50 data elements. So instead of a fire hose of data, to your point around cybersecurity, instead of a fire hose of data coming out of my EHR, let's be a conduit of quality of data that's being shared. And so as we've worked with these provider-sponsored health plans and the providers, it's giving comfort on both sides of the equation of like, look, let me lower your operational burden on the health plan side to decipher where that data is, while giving control and a comfort for the provider to know that whatever you're using to pull the data out of my EHR, that you're doing so in a manner that is, in alignment with minimal necessary and only sharing the data that absolutely is needed to review that patient's chart, right?
So this is the concept of the different mindsets that you'll have.
Very much so.
In these organizations. So I do this, and not just because I'm ambushing you with a question, but because I do it with a lot of my sessions. I like fireside chats like we're doing right now, but I also like fireside spats.
Yeah.
So I'm sort of curious what in these organizations that you're working for, I always find that there's great value to find out who's bickering with each other. So I mean, on a day-to-day basis, are you operating as the United Nations in some ways across both of these groups? Because it must be hairy territory.
Well, I've learned in being married for 17 years that you can't argue with someone who agrees with you. So when I'm told that I'm ignorant and dumb, I say you're absolutely right. So I try to stay away from the argument. But I will say that I think, if you were to look like where the bickering is happening, it's primarily in the mindset of the individual, right? So as much as we want to believe in the holy grail of value-based care and that we're doing the right thing for Frank and Brad as patients, providers still operate on a daily basis under a fee-for-service of volume. I need to see more and more of these patients, whereas health plans operate more in a risk stratification model, right? I'm trying to avoid, I want you to be seen, but only be seen enough to check the box on the care gaps that are ongoing and make sure we're taking, really good care of you. And so when you get that sort of abrasion and friction, right, you sort of lead to a little bit of a different, model of, what are we doing? And so this is where I think what we will see happening in the next 3 years that 3 to 5 years that we're not talking about right now. And you see, we're doing some early work with some of our health plan partners around this is how do I take insights that the health plan has on Frank and Brad and influence the provider's behavior within their workflow. So
hyper-personalization.
Yeah, so very much like, because, and I think it behooves both the provider and the payer to do it. If I'm going to enter into a value-based care model with a health plan and a provider, let's work on tools that allow us to really provide value-based care where we're collaborating. So what could that look like? Oh, I have claims data as a health plan. I understand care gaps, diagnosis gaps that have happened for Brad, or he was diagnosed with this condition at X, Y, and Z facility that may or may not be within your EHR. Let's notify you to do that work, right? But I've got to notify the provider where? Inside that EHR. Because we've learned of anything, the last thing they need is another system to utilize and to access, right? And so making that easy, and I think this is where I think provider-based health plans have the biggest opportunity to really leapfrog the large nationals or regionals or state blues, is because if they're able to take their population and provide insights into that provider's workflow, and we're starting to close care gaps and recapture, those diagnoses for those individual patients, like we're ahead of the game because now we're collaborating, and it's not like infighting of like me telling you something and go, well, I didn't take action on it. Why not? Well, you didn't tell me, how did you tell me that, right? And so I think that for the most part, the value-based care concept is great on paper, but until we get to that collaborative model of really taking data from point A on the payer side and moving it back to the provider, I think we're going to be missing the boat on what's truly, could be realized, I guess.
Let's take it to the consumer side, which we all are, to say, unless we're uninsured.
Yeah.
So, is there a perception, accurate or a misperception, that having a payer that's part of a provider organization is going to be more streamlined in more of the most contentious areas of healthcare, prior authorization, or something like that?
I think that's the biggest piece, is like making sure. I think that 100% for employees of a provider, like if I'm an employee of Texas Children's or insert Geisinger and Geisinger Health Plan, the assumption would be that it will be easier for me to get that prior authorization processed, or I'm being communicated to more proactively around what's required to take the next step. What's been realized? I think the jury's still out, right? So I think what we're seeing, even with CMS is really pushing a lot on the prior auth this year, that folks are having to report out on the analytics of prior authorization. I think 2027 is going to drive that even further from a mandate standpoint. I'd love to come back and talk to you next year about it. I think he who predicts the future lies. I will say that I think that for those who are doing it appropriately, meaning that they are collaborating and they've got truly I will say an interoperable framework between both sides of the coin, I think they're going to start to see and realize the value there. And ultimately that drives better care, member satisfaction, right, around the fact that I didn't, get denied or have my prior authorization denied to have the next procedure or treatment.
So when you come to a show like this, what are you seeing in terms of, and you're producing some of this as a provider yourself, as a partner yourself, what are you seeing in terms of the way that people are approaching, I'm not going to say the word AI, the letters AI. How do you see that they're approaching this for something like prior authorization using these new generative technologies and robotic process automation and things like that? Where's the action?
Yeah.
For you at a show like this?
So I actually had an opportunity to interact with a couple of CIOs that we work with this morning and had the same conversation. And I would tell you, I think a lot of it, and actually it's funny to see, like, and I asked her, I said specifically, so what are you trying to get out of the show? She was like, a lot of it for me is to make sure that we're maximizing the vendors we use today. And just like any organization, be it Chime, MRO, UCLA Health, etc., they're all, the CEO comes in over the weekend and says, oh, I read this article about, or my 15-year-old's doing this in AI, what are we doing?
Exactly.
And so it's been really interesting that a lot of the constituents and like attendees of the show are really here more to say, how do I communicate what it really is, what's myth versus reality, what are the baby steps and the crawl, walk, run for us to get there, at least on the AI front.
Yeah.
And it's going to be interesting because, like, if you really kind of peel back the onion, is it AI, is it machine learning, is it NLP, and so I think we have to kind of, really define the space. And right now, with the freedom of marketing, we have a lot of, euphemisms and buzzword bingo.
Okay.
Same thing for interoperability, right? Like, one of my biggest challenges, having sold health information exchanges when they were called Rios and Chins and Lins in Canada, is that we have this belief that, like, integration, interoperability just is what it is. And I'm going, just because you've sent an HL7 message does not make you an HIE, right? Nor does it make you an interface engine. And so I think one of the challenges, and this gets back to sort of the provider-sponsored health plan piece and the providers exchanging data, I've been a big advocate for we need to focus more on the quality of data being exchanged, not just that data's being exchanged. I could send a feed from point A to point B, but if it's not the right information, and I'm just sharing the data for sharing's sake, I feel like we're missing the boat.
Yeah.
I think that, so I think that's the one thing that I wish that the industry as a whole would get a little more granular on what true interoperability is, what's the value abstracted, and similar to, everything that we're trying to do in the world of AI. Because ultimately, I'm not going to trust that it's the end-all be-all. Could it lead to operational efficiencies, administrative burden being reduced? 100%. I think we've seen it in the way I craft emails and help my 16-year-old with his homework. I'm using AI. But at this, for sure, yeah. Oh yeah, no, I don't know if he's that happy. I don't have the greatest test scores for him so far. But I think it's like we're all trying to take advantage of it. But the jury's still out. But I do think a lot of folks are going home going, all right, everybody, here's our plan for AI. This is what I saw and heard. It's like kind of level setting.
Wait 15 minutes and say, I'm sorry, I changed your plan.
Yeah.
So, are you finding, I'm wandering here a little bit, but it makes me curious, and especially with data folks, the challenges now because of AI in relation to the retirement of data. Mm-hmm. That now there's the perception, which might be true, and misperception, it's been here a long time, and now suddenly we can make it more valuable, almost in retrospect. Do you find it difficult to get people to retire?
Oh, 100%.
Is that the conflict?
I mean, if you see like the folks,
it's like me cleaning up my emails.
Yeah, absolutely. Like, no, it's like it's never gonna go away.
So that's human nature, right?
Well, and I think it gets into the granularity of not only the retirement of the data, what's the data insights that we can glean from it. If you start to dive into a lot of these AI vendors and what they're attempting to do, they're going to get more granular around data rights, being able to quote unquote train their data models, right? And so when they start to contract and pilot or further, they're saying, actually, no, I need to be able to have data rights so I can train my model, right? Doesn't mean that they're monetizing the data like a Flatiron would back in the day and, go into biotech or pharma, but more that I need to be able to leverage that data in order to train the model on, I'm trying to find patients with, chronic kidney disease or, insert disease, right? So I know the storage of the data at some point point, right, we've got to figure out a cheaper way to do that. But I don't see anybody getting rid of it anytime soon, because I think that's still the gold in healthcare, right? It's the oil from the ground that you're able to pump and say, well, that's what's driving the system. It's giving the analytics and insights for the health plan. It's impacting the way that providers are behaving and the way that they're treating the patient. So I don't think we're going to retire it anytime soon. I still see it happening and kind of being there now. How we can leverage it once it's somewhat in steady state, I think there's probably a lot that we could probably look at from that standpoint.
We wrote an article about the retirement guide for aging content.
Yeah.
So, and people engage with it because it really.
Yeah.
Everybody's arguing you can't get rid of this device, we can't get rid of this database. So
no.
It's a huge thing that.
Well, there's vendors that as you go through like vendor kind of EHR switch offs, right? They say, hey, don't pay the licensing fees of all of these vendors, just port it over into my repository. I'll hold it, and then as you move over to X, Y, and Z, EHR, you'll have the data there. So that's been there's a whole niche market for that. But
we have about 5 minutes left. I want to make sure I let you talk about. I mean, the market noise out here is ridiculous. I mean, agentic AI. If we had a penny for every time it was said, and a dollar for every time it was meaningful,
right?
So what do you? I mean, what in your competitive landscape? What do you have to do at MRA to make yourselves different?
Yeah. I mean,
content-wise, or go to market.
Good question. Look, I think that we have to understand what's really our DNA, right? And we have serviced providers for 25 years. I think that there's any number of legislative pressures or industry pressures saying that the way requesters or health plans are asking for data from providers is changing, right? Be it CMS mandates, be it for FHIR, be it the NCQA pushing for digital measures for HEDIS. And so for us to be successful, we've got to continue to serve the community that we work with, right? And that means not only making sure that I'm keeping you as a provider compliant from a privacy standpoint, a HIPAA compliant standpoint, and knowing that I'm not streaming your data all over the community, but also on the requester side to ensure that, hey, Mr. or Mrs. Health Plan, you're getting the data you need to drive your business. And how can we serve you better? How can we take a member eligibility file and look for any eligible encounters? So instead of you asking for, want one, get one, where I ask for a chart and I get one back, I'm actually proactively pushing you data from the provider based on your membership to say, hey, we want you to know about Brad's episodes of care. So now we're starting to shift the model from let's rely on claims data to let's drive that clinical data to really be the leading indicator of how are we treating these members. Gets back to the collaboration model between the providers and the payers, right? And even in that provider-sponsored health plan, if they can do that, they can get ahead of the game for sure.
So in closing remarks, I mean, if we have CIOs from both provider and payer organizations watching our program today, what are some words of advice that I just came back from Vive and here's something you should think about a little bit differently?
Yeah. I think the biggest thing that they've got to focus on both sides is who's asking for my data, how am I giving it? At least
internally and
externally. Like how, because I'll give one example. There's a provider-sponsored health plan that goes through a third-party intermediary that then comes to MRO because we work with their provider group, and it's their provider-sponsored health plan. So they're adding complexity and cost to that entire arrangement versus saying, hey, I'm just going to go to MRO and get the data because they already have access to it. So there's a lot of splinter cell IT, right? Well, I create a supplemental file over here, or I create a data extractor. These guys have direct access to our EHR. I think we've got to really take an inventory of kind of who's got hands in the cookie jar. Who am I passing out cookies to?
Well, there's shadow stuff out there now. The shadow AI right now is probably one of the hottest topics that you can still use AI in here.
Yeah.
People would say, okay, it's not boring. Tell me more about it.
Yeah, exactly.
So this has been fantastic.
Yeah, no, Frank.
Longer than a half hour.
No, I appreciate it. Thanks for the time. Absolutely. Thank you.
Thanks very much. Thank you for joining us today at Vive and our Time Health Stealth Radio broadcast. Please stay tuned, and we'll see you for the next show.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.